Good evening. This is MedSurg Nursing, Brain Disorders. This is part 2, looking at stroke and aneurysms. First, we're looking at transient ischemic attack. This is a brief interruption of blood flow and it has a sudden onset. Warnings are usually of more serious neurologic events, usually within 90 days. Symptoms generally last no more than an hour and completely resolve without residual defects. And through history, how it began, length, and symptoms is what we're going to be looking at as well. Now, understand that the TIA could be maybe there is a partial compression where it is causing blood flow to decrease through an artery or so, and then causing symptoms, and then all of a sudden there is dilation and you have more blood flow. And so once again, this is only a transient attack, not a full-scale stroke. Once again, diagnosis could be carotid duplex ultrasounds, maybe blood tests like an MRI or EEG determine carotid occlusion. This here could cause the TIA, once again, if it's intermittent occlusion. They may do an angioplasty procedure or stents through the carotid or a carotid endarterectomy where they actually open up the vessel and clean it out. Other things that they could do is diet, lifestyle modification, and medication to prevent platelet aggregation. So typically when they have symptoms, or they should be on a regimen of like aspirins or something like that. Moving on, we're looking at cerebral vascular accidents or stroke or brain attack. So we're going to look at etiology, the risk factors, and the pathophysiology typically is related to cerebral thrombosis or a blood clot, an embolus. It could be either a clot or it could be a hemorrhage where pressure on a blood vessel and it ruptured. So in this picture, it shows that here there's a clot that occludes, and so the area above that does not get oxygen. So we're going into hypoxia and anoxic events. Over on this other picture here, it shows there's a rupture in the blood vessel, so that is more hemorrhagic as an event. Also, some of the risk factors talks about dangers of cocaine and meth. Once again, both of these can cause severe vasoconstriction and brain ischemia. Cocaine can cause hemorrhage. Using these drugs increases your incidence of stroke 5 times. So incidence of this type of stroke is highly greater in young adults. So that's quite unusual. The other one would be a cerebral aneurysm and an atriovenous malformation. So an aneurysm is actually an abnormal ballooning of the arterial wall. So that wall does become weakened. And then the arteriovenous malformation is just a congenital abnormality that is a tangled mass or malformed, very thin-walled, dilated vessels that form, and then something happens, hypertension, and then it ruptures. So in this picture, it shows a cerebral aneurysm. So you have a weakness here, and this bulging balloon of a vessel can rupture, and that would cause it to be a hemorrhagic stroke. Here, this other picture is showing when they're doing an angiogram, not of the heart, but of the brain, and it's showing that there is malformation as well, which once again is a weakness of the vessel and stuff, which could cause, once again, a hemorrhagic stroke. So let's look at some warning signs. We need to teach people to seek immediate medical attention in the ER. They have sudden weakness, numbing tingling, loss of the feeling of the face, arm, or leg, sudden trouble seeing one or both eyes, sudden confusion, slurred speech, trouble talking, or difficulty understanding others. So that could be indicative either of a TIA or actually having a stroke. Additional warnings: a sudden severe headache for no reason, sudden trouble walking, dizziness, or feeling spinning around, loss of balance, or having blackouts. All these could be indicative of a stroke. Additional ones, ask the person if you're thinking that they're possibly having a stroke. Ask them to smile, shrug the shoulders, repeat a sentence, or tell you who they are. Any one of these, we're actually assessing their cranial nerves. If they are not able to tell you who they are or repeat a sentence, it could be other areas in the brain that is being affected as well. Signs and symptoms, once again, it depends on the location of the clot or the bleed. Remember, a stroke could be either a clot or hemorrhagic. It could be motor function deficits. It could be caused from language disorders in the Broca area of the brain, emotional responses. It could impair memory and judgment, definitely spatial perception deficits, and bladder and bowel incontinence as well. Let's stop for a second and look at clinical clues. Valve disorders and arrhythmias such as atrial fibrillation and emboli that form because of valve abnormalities can actually predispose the patient to having strokes, because both of these can create clots or little emboli that break off and travel up into the brain and causing havoc. Diagnosis of a stroke, once again, they're going to do an MRI, a cerebral angiogram, an EEG, or brain scans like a CT. So time's of the essence. They're going to do it immediately. They may do a transcranial Doppler flow studies, a carotid artery, because we're trying to identify where the stroke is. Is it a clot that's in the carotid arteries, or is it up inside the brain and stuff? Testing for blood levels for glutamate. This measures the progression of the stroke. So as these levels rise, this means that the stroke is still evolving. So carrying on, and we need to take care of that. If they do thinking it's a hemorrhagic, they may do a lumbar puncture, which will see that there is blood in the cerebral spinal fluid. Stroke treatment, once again, main objective, maintain the open airway. Keep that head of the bed up. That head of the bed up actually decreases the intracranial pressure. We're going to treat it with fluids for hypovolemia. We're going to treat antihypertensive. Once again, this is just a range. A blood pressure higher than 220 over 130. Once again, it could be a little bit lower, but it depends on the patient. We're going to maintain a temperature control because, once again, it all depends. The hypothalamus may be on the blink, and we may have to do a hypothermia blanket because if the temperature is too high. They may do alteplase or systemic tissue plasmin, ATP, TPA, or whatever they choose, but these are clot busters. If it is not a hemorrhagic, if they find out it is a clot, they will use the TPA to break up the clot and get it more reperfusion occurring in that area. If it is hemorrhagic, they may choose to do surgical procedures, however they see fit. Here's another clinical clue. There is a fine line between keeping the blood pressure high enough to perfuse the brain when an obstruction is present, but keeping it low enough to prevent the vessel from rupturing. So once again, that is a very delicate tight wire to walk. Complications, once again, the main thing is extension The hemorrhage or rebleeding could be a problem. We may end up having seizures. Once again, seizures, remember we talked about hypoxia and anoxic events. This is why. And having hydrocephalus. Remember, hydrocephalus, if there is any bleeding, that could block the cerebral spinal fluid from circulating around into the brain, into the spinal cord area, and then causing hydrocephalus, which would actually increase your intracranial pressure and causing more problems. This image here just shows you a comparison of deficits. Left-sided brain, and they're a little more cautious. They may have some other problems, difficulty performing simple tasks. Your right-sided, they're more impulsive, short attention span. These that are on the right-handed side, brain damage, I would say they're more concerned because they are impulsive, so they're more at risk for additional trauma, falls, and such. And then recovery. Once again, there is 3 phases of recovery. Once again, we're going to look at maintaining adequate airway, establishing baseline data regarding vital signs, level of consciousness, neuromuscular functions, neural status, preserving the patient's joint and muscles, and preventing complications. Phase 2, once again, we're going to go on for rehab. Now we should begin at the moment the patient was admitted. So various members of the healthcare team, we have speech, occupational therapy, physical therapy, all there to help them and help the family with psychosocial issues as well, because the patient may have mood swings, spontaneous weeping, and that could be just because of the brain injury. And last, phase 3, once again, this is discharge. Now we're looking at referrals, maybe home health, visiting nurses, continuing rehab outside the hospital as well, and making sure that they get the sufficient support to maintain that rehab outside the hospital, because that's going to be intensive rehab 3 days a week ongoing. And that finishes our PowerPoint.